A healthy heartbeat is a mechanical event driven by a strict electrical sequence. Understanding this failure requires treating the heart as a biological circuit. This split-screen diagram maps anatomical conduction pathways against the resulting ECG trace. The wave begins in the sinoatrial node, spreading to the AV node, drawing the initial P wave. The signal travels down the His bundle, splitting into the bundle branches to trigger ventricular contraction, forming the QRS complex. A heart block is a localized failure, a break at the AV node, His bundle, or the bundle branches. By tracking the depolarization wave from the atrium down to the bottom of the ventricles, we can systematically deduce where the wire is broken based on the shape of the trace. Reading an ECG is an exercise in diagnosing a physical break in a circuit. Understanding these mechanics eliminates the need to rely on memorized wave patterns. Our assessment begins at the AV node and the His bundle, the junction where atrial signals cross into the ventricles. This trace demonstrates a normal PR interval, representing the total travel time from the SA node to the ventricular muscle. In a healthy heart, that journey takes no more than 220 milliseconds, or 6 small squares on the grid. If every wave of depolarization reaches the ventricles, but the journey is slowed at the junction, the PR interval stretches beyond those 6 squares. This is first-degree heart block. A simple delay keeps the rhythm intact, but if interference at the AV node causes the signal to fail intermittently, we move into second-degree heart block. In this ECG trace, the PR interval starts at 260 milliseconds, then lengthens to 280, then 320, until a P wave fires and nothing follows. This progressive fatigue characterizes the Winkelbach or Mobitz type 1 phenomenon. The blocked beat allows the AV node to recover. Consequently, the very next conducted beat resets the cycle with a noticeably shorter PR interval. Compare that to Mobitz type 2 block. Here, the failure is sudden. A standalone P wave appears without warning, failing to trigger a ventricular contraction. In this variant, the baseline timing remains steady. The PR intervals surrounding the dropped beat are rigidly, mathematically constant. This failure can also follow a fixed ratio. The node might conduct 1 beat and drop the next 2 or 3, resulting in 2-to-1 or 3-to-1 conduction. These dropped beats require careful inspection. An isolated P wave may not land on a flat baseline. It can fall directly on the previous cycle, appearing only as a subtle distortion in the T wave. Whether it is a delay or a dropped beat, every block situated at the AV node or His bundle manifests as a disruption to the timing ratio between the chambers. Third degree or complete heart block occurs when the electrical bridge is severed entirely. With the connection broken, the atria and the ventricles decouple and operate as 2 independent systems. On this trace, the sinoatrial node continues functioning perfectly. The atria contract at a steady rate of 90 beats per minute, placing P waves uniformly across the grid. Since the ventricles receive no signals from above, they rely on an escape mechanism. A secondary focus within the ventricular muscle begins generating its own electrical pulse to maintain a rhythm. This results in a dual-rate ECG. The regular atrial rate of 90 is superimposed over a much slower ventricular rate of 36 beats per minute, with no mathematical relationship between the two. Because this escape pulse originates in slow-conducting muscle tissue rather than the high-speed bundle branches, the resulting QRS complexes appear wide and misshapen. Third-degree block destroys the heart's hierarchy. Instead of a single heartbeat, we must identify 2 overlapping but distinct pacemakers on a single strip. We now move below the His bundle to where the pathway divides into the right and left bundle branches. A block down here leaves the PR interval unaffected. The signal reaches the central septum on time, meaning the delay occurs entirely within the ventricular mass. Healthy ventricular depolarization is rapid. The signal must travel from the septum to the furthest edges of both ventricles in less than 120 milliseconds, or 3 small squares. If a bundle branch is blocked, electricity is cut off from the primary highway. It is forced to travel cell by cell through the muscle tissue to reach the rest of the heart. Muscle tissue conducts electricity slowly. This detour mathematically forces the QRS complex to stretch wider than 120 milliseconds on the paper. While other conditions can widen a QRS, A bundle branch block during sinus rhythm is always preceded by a normal P wave and a constant PR interval. The clinical stakes depend on which branch is broken. Right bundle branch block patterns can appear in healthy individuals, while left bundle branch block almost always indicates disease of the left ventricle. Crossing the bifurcation shifts our diagnostic focus. We stop looking at the timing between chambers and start evaluating the width and shape of the ventricular contraction. To analyze these shapes, we use two primary leads, V1 looking from the right and V6 looking from the left. In right bundle branch block, the failure occurs in 3 stages. First, the septum depolarizes normally from left to right. This pushes electricity toward V1, drawing an upward R wave, and away from V6, drawing a small Q wave. Next, the massive left ventricle depolarizes normally. Its powerful vector points away from the right side, dropping V1 into an S wave and pushing V6 into a large upward R wave. Finally, the right ventricle depolarizes late via slow muscle conduction. This creates a secondary vector pointing back toward the right, drawing a second upward spike in V1. We label this second spike R1, creating a double-peaked signature known as the RSR1 pattern. That same late rightward vector pulls electricity away from the left side, which is what drags lead V6 down into a wide, deep S wave. If an RSR1 pattern occurs, but the total width remains under 100 milliseconds, it is classified as a partial block, usually a benign variant. Right bundle branch block physically splits the ventricular contraction into 2 sequential events, creating a double-peaked signature on the right side of the heart. Left bundle branch block occurs when the primary wire to the heart's largest muscle mass is cut. The septum depolarizes backward, right to left. V1 draws a downward Q wave, V6 an upward R wave. The right ventricle fires, causing notches in both leads. Finally, the left ventricle fires late. V1 dives into a deep S wave. V6 forms a broad, notched R wave. These vectors produce distinct visual patterns, a deep W shape in lead V1 and a broad, notched M shape in lead V6. Severe left bundle branch block is also frequently associated with inverted T waves in the lateral leads, such as V6. When we view the conduction system as a whole, a clear diagnostic map emerges. Blocks at the AV node and His bundle are timing errors. We diagnose these by measuring the PR interval. Blocks below the bifurcation are vector errors. We diagnose them by evaluating QRS width and the specific shapes appearing in leads V1 and V6. Mastering the ECG is not about recognizing patterns in isolation. It is reverse engineering a physical break in the